Very welcome to this state-of-the-art extraction program. This online ERA satellite symposium is generously sponsored by Philips. The target audience this time is not referring physicians, but mainly extractors. This session will discuss three presentations by three distinguished extraction colleagues. We have strict timelines, meaning we have 15 minutes in total, so we'll spend 5 minutes on each presentation. My name is Charles Kennergren, Gothenburg, Sweden, and my co-chair is Professor Antonio Curnis from Brescia, Italy. I'll take the lead on the discussion of the first presentation by Professor Pascal Defay from Grenoble. His presentation is Being Successful, Tools for a Difficult Case. If you've seen that presentation, it's very helpful for understanding this discussion. So, Pascal, I have a first question here. You line up different approaches, which is essential to guarantee success and safety. Would you comment on the possibility of using a hybrid approach in difficult cases, meaning that you combine transvenous extraction and open chest extraction? Could you please give your comment on that?
Yes. In fact, it is a case of a very, very old lead. The first lead was implanted in 1981, so around 40 years ago. And probably we can think that it will be a very difficult lead extraction. And in that case, the risk of extraction can be important. And in this case, we have two solutions. First solution, extract only percutaneously. And the other solution, as you said, Charles, is to have an hybrid approach with a surgeon. But in my center, we have no experiences of hybrid approach with open heart surgery, associated open heart surgery. I think it can be a solution, of course. Perhaps we can try to extract percutaneously, but don't hesitate to stop if we have some difficulties, and to go to an hybrid approach if it's too difficult. If we have if we are surprised by some very hard adherences, for example, of course. But I have no experiences, Charles, of hybrid surgery. I think that you and Antonio have experiences of hybrid approach.
I bring up this subject because I quite recently reviewed a paper from a German center describing a number of cases done with this approach with excellent results. And especially for old and difficult leads, I think this is the way we're going in the future, combining the expertise of surgeons and cardiology extractors, because as we all know, if we're surgeons, doing open heart extractions is not so easy as some colleagues would assume. So using transvenous techniques in that setting is a very successful way to go. Antonio, what's your perspective?
Just one very short comment. In fact, you know that there are a lot of of discordances between the year of implantation of lead and the level of adherences, and sometimes a lead 40 years old have very few adherences. So it's difficult to decide.
Absolutely. But Antonio, let's give Antonio the chance to comment.
Yeah, we have. Thank you, Charles. I think we have to distinguish two periods: before bridge balloon and after bridge balloon. Because before bridge balloon, I think that hybrid approach will be useful. After bridge balloon, we can start first with transvenous and surgeon beside. We use a hybrid approach using thoracoscopic view. This means that we are able to control superior vena cava and atrium. We use a different type of hybrid approach. We use thoracoscopic approach. So this means that the surgeon can follow us using thoracoscopic view without open chest, but just a thoracoscopic, 3 small scars. And we can do this very difficult case. But again, before bridge balloon, it was more useful. After bridge balloon, we can do more risk patient because we have more safety using bridge balloon. So we don't need to do this procedure by open chest first, but we can start with just transvenous extraction. I don't know. What do you think?
It's an excellent take, and I remember the video you showed us extracting CS leads with a thoracoscopic approach. So the competence of the local center is essential, I guess, for what approach you prefer. Volker, do you have a comment on this?
Well, we have an approach. The first step is always transvenous. And but we are working in an OR, so we have the chance to change or to do a hybrid approach if it's necessary. We had one case, I remember, there was a first attempt made in another hospital, and there were a lot of stuff inside, and so actually we had a secondary infection of remaining lead parts of the lead, so we had to do a second approach using an open chest surgery and just to try to remove the other parts by sheath putting onto the leads. So it's a kind. So not only one case, but it's a kind of hybrid approach. But mostly we start with a transvenous.
Right. Now, we always start transvenously in so to say normal cases, but sorry, my starting point was Pascal's difficult case, and in selected cases we found it extremely useful from a safety point of view to have an open chest so you can see a perforation as it happens. So I'd like to summarize this discussion and say it's pretty essential to work together, cardiologists and cardiac surgeons, to have the opportunity to employ the optimum method, the optimum approach for every patient. I have a final one for you to comment regarding leadless devices. What's your take as an experienced device physician and extractor? Do we have to abandon? Do we need to abandon? Can we just abandon leadless devices, or will we have to extract these as well in the future? A brief comment, please.
Yeah. In fact, you know that it depends on the kind of leadless. For NanoStim device, it's relatively easy to remove a NanoStim device because we have a specific tool to retrieve the leadless. So we had only one failure of extraction with NanoStim, and it was the case of failure. All the other cases, we had success of extraction of all NanoStim. For the Micra, it's very different because it's more complicated to extract because the device is shorter and probably there are more adherences. So I'm not sure concerning the future, but probably if we will implant leadless for younger patients, we need to probably to try to extract some leadless, and it's why with NanoSteam we try to remove the leadless.
Thank you, Pascal, and thank you for sharing a very interesting case with you on your video. So I'll go quiet. Antonio, it's all yours.
Thank you, Charles. No, just one small comment from the presentation of before. Volker introduced an important concept to difficult case: patient treated in other center with damaged leads. This is an important point. They are really very damaged, very dangerous patient, because you don't know what the previous operator did. So you see just damaged lead, but you don't know how damaged is the vein system. So they are very high risk patients. So in this case, we have to teach to beginner or not beginner, but not so skilled, to do not damage the lead, to stop the procedure, to send the patient to more skilled center. What do you think about Volker?
Oh, I totally agree. I'm thinking about, and this is a subject of my presentation as well, to be networked together, just to educate or to give the possibility to others to have the information they need. I see so many leads which are just cut under the clavicula or which are pulled till they tear, so, and you have no possibility to put a LED inside and so on. You all know these cases, and this is one of our tasks to be connected to all these centers who think they're doing well, but they don't do. That's the problem, I think.
So I have another question for you. Connected with other center, sometimes patient coming to our center very sick with endocarditis, with kidney insufficiency due by long, prolonged antibiotics therapy, and so on. So I think that we have to teach referral center to send this patient earlier to us.
I think that's one of the big messages our German study, the gallery study, says us. We see that the mortality, the procedure-related mortality is very low, but the in-hospital mortality is very high, around about 3.55%. And we were asking, what's the reason of that? And I think one possible answer is that they are sent too late. They are treated with 3, 5, 4 antibiotics. Someone pulled at the lead or put the device under the muscle or something like that. So the message must be sent it as soon as possible.
So we found in some of these patients a huge vegetation. Sometimes it's a mixed vegetation of bacterial and fungine vegetation. So what is your strategy in this case?
Well, we try to find out what is the size and what is the geometrical form of this vegetation. And first of all, if it's more than 3 centimeters, or there we have only the possibility to do an open chest surgery. I don't think that's a really good idea to do a transvenous approach, but we try to remove them all, and we tried at first with a laser, just thinking about kind of vaporizing some vegetations of that, and they are treated afterwards with antibiotics as well.
Antonio, can I chip in?
Yes.
Regarding when patients are referred and size of vegetation, it's my distinct experience that almost all the really big monstrous vegetations we've seen have been in patients who were delayed in being referred. Is that the feeling you have as well, guys?
Yeah.
Yeah.
So you really made the point there, Antonio. Refer early.
Yeah, this is crucially important. Also, not only the mortality, but also the hospital stay. It's very, very long. The cost of this to treat this patient, to manage this patient, even if he's successful, is 10 times more than the conventional patient.
Right. You remember the Electra data. 2/3 of the in-hospital mortality was not related to the procedure, but to serious infection, killing the patient after a successful extraction. Do we have Roger with us?
Yes.
Oh, glad to see you again, Roger. You know, actually, in the interest of time, I'll bite the bullet a little bit here and ask you two clearly defined questions. What are the 3 most important precautions to avoid complications? That's the first one. The second one is, what are the 3 most important precautions to avoid mortality? That's not the same thing in my book. So 3 most important precautions to avoid complication and then mortality.
Great. I think to avoid complications, you need to have a very good planning of the procedure. You need to know the indications. You need to know the patient's conditions. Not all the patients are the same. There are some patients that are taking steroids. There are some patients that are renal failure. And then you need to know the leads, the type of leads, the design, so forth. And what we have learned in the last 10 years is that we are able to assess the adhesions in the superior vena cava, and we're able to anticipate if an extraction is going to be easy or is going to be more difficult. So we have seen some pacer leads, 20, 30 years old, with little adhesions in the superior vena cava, and we have seen 5, 6, 7 years old leads with severe adhesions in the superior vena cava, and that give us a glimpse of how much trouble we're going to have. So not only we can anticipate the potential occurrence of complications, but we can be prepared for it.
Right.
Once you have a complication, then you have to be ready for it. You need to have a team that have a surgeon present and a perfusionist and anesthesiologist capable of rescuing that patient, because time is of essence. You have to put a bridge balloon in order to minimize exsanguination before the procedure. In that way, you can have a better survivor than without the use of a bridge balloon. So you need to be prepared to make sure that if you have a complication, doesn't mean a mortality. No. And that a surgical team, an anesthesia team, and the use of bridge balloon on these cases.
Right. So what role do you think the EF of a specific patient plays in the context of a positive or negative outcome when you have a complication?
Well, the ejection fraction of most of our patients is low, below 30%. 80% of my patients have an ejection fraction below 30%. So therefore, most of the patients that have complications in my center, they have low ejection fraction, plus sepsis, plus renal failure, plus the other conditions. And if you take all the preparations, surgical management of this complication is usually very successful. You have survival in the range of 80 to 90%, even with such a bad substrate. But the key is on the preparation. If you're not prepared, if you don't know what to do, if you don't have the saw when you need it, if you don't have a bridge to avoid exsanguination, then you are not going to have a survivor. And if you do have a survivor, without being prepared, maybe he's not going to do well. His neurological status may be compromised, or his other organs are going to be compromised. So the key on making a survivor out of a complication is to have good preparation before the procedure.
Thank you, Roger. Do we have other comments from the panel on this subject, please?
Yeah, I have a comment. I think in our center, we start lead extraction the day before. This means that you need to know the patient, because sometimes they are referred patient. So they send to you a patient with 2 leads, and suddenly in operation room, the lead became 5. They said this 2015, and at the end is 2000 or 1995. So you need to know the condition of the patient, the hardware, if he needs pacing or not, if he is infected or not, and the strategy also after extraction. So this play an important role. For example, if you have an infected patient with biventricular device and he needs to be paced, what to do? In this case, we implant an epicardial pacemaker before, and then we do lead extraction, because this make more safe. You reduce the infection, you reduce the treatment of this patient with temporary pacing, for example, and so on. So the strategy before and lead extraction means 360 degree to know all the condition, all the situation, almost in patient with very difficult case. I don't know, this is my suggestion, if you agree.
Points very well taken. I'm afraid we're running out of time now. Antonio, would you mind summing up, if you can, what we've discussed today, please?
Yeah, it's not so easy to summarize in 1 minute, but I think the presentation of Professor Pascal Defayet, point out difficult case with different strategies, and this is more important. If you want to do a good approach, you need to know and you need to have all devices in your center. So you need to be able to use laser, you need to be able to use mechanical, bird sheets, all possible. This is the key point, to have safe and full successful rate of lead extraction. This is crucial important. Thank you, Pascal, for this presentation. For Volkmar, I think he pointed out another important crucial point. This means have a good cooperation with other centers. Give some message, send the patient earlier, don't treat patient for a long time, and this make the procedure easier. If you're not able to do procedure, don't damage leads, leave the leads on the body, and we will do this safer. For Professor Carrillo, I think you point out the most important. We have to prepare our intervention day before and be able to contrast all difficulties. This means using bridge balloon, have a good relationship with cardiosurgeon, and the cardiosurgeon need to know what we are doing. This means he have to be able to repair superior vena cava bleeding or different type of situation. This means sometimes coronary sinus lesion. Coronary sinus lesion by extraction means you have a lesion of the myocardium. It is not a bleeding, just a bleeding. It's a bleeding of a piece of myocardium, and this is more difficult to be repaired. So I think in this session, we explore the all part of difficult lead extraction, and to make this in 100% or 99% successful with very low risk. Thank you.